На открытие он открывает, читает свой доклад и отвечает на вопросы. Дальше отключается. Это понятно?
Он первый выступает?
Он первый выступает, он открывает. Да, он первый выступает. Майкл выступает первый, садись. Да, Майкл выступает первый, отвечает на вопросы и отключает, потому что у него потом там клиника. Все, ладно?
Хорошо.
Да, и сейчас он первый. Он сейчас первый выступает, Майкл. Я же вам говорила, программа.
А вы потом поможете мне подключить, да?
И мне нужно с ним поговорить, с Майклом. Там сейчас как, надо сейчас вывести, чтобы была картинка, меня было видно, Майкла видно и Киселеву Марину Викторовну. Вы пока присядьте, Ирина Александровна. Майкл есть, правильно?
Dr. Segal, have you checked the English language?
I've checked the English language box, yeah, and I have also checked the mute box.
Yes,
Сейчас, если у меня
that's
тут
correct.
телефон.
Yeah.
Thank you.
Техническая служба. Мы можем начало, да, чтобы видно было Майкла Секла, меня видно и Марину Викторовну, чтобы было видно на экран для всех. А? Да, вот чтобы в самое начало такое было. Ладно? А потом мы переключаемся на Майкла с его докладом. Только что-то Марина Викторовна не отвечает. Она у вас подключена, да?
Okay.
Мы начинаем, Леонид?
Сейчас мы Марину Викторовну.
Леонид? Леонид?
Марина Викторовна подключилась, нет?
Dr. Segal, could you please start sharing your presentation?
I've already done that. I put it
Да,
on to
Марина
share.
Викторовна,
Can you
здравствуйте.
not
Как у
see
вас
it?
получается подключиться?
Says screen share.
Вот
Can you
что-то
not
они
see
вас
it?
не видят технически
Yes, I can
наш, потому
see.
что Майкл у нас уже
I can put it onto
подключился.
presentation mode if that helps you now.
Ну вот в 1:30, если у вас будет
Is that
возможность, чтобы мы
okay?
открыли. Да, да,
Yes,
чтобы мы
we
сейчас
see
все
it perfectly.
встретились. Ну,
Perfect.
ближе к двум
But we
доклад ваш, а
haven't
чтобы
gone
вы
live
открыли вместе с нами.
We're not live yet, no, okay.
Давайте. Сейчас Марина Викторовна подключается. Скажите Майклу, что сейчас подключается московский еще спикер.
Our speaker from Moscow is connecting right now, and right after she will connect, we will start.
Okay, fantastic. Thank you, Yulia.
Thank you.
А Майкл сейчас меня не слышит, да? Он меня может... Вот сейчас он слышит меня, Майкл? Майкл, can you hear me? It's Елена.
I can hear you very well, yes.
Oh, Michael, so glad to hear you. I cannot see you right now, but I can hear.
Elena,
Thank you so
hi.
much. Thank
How
you.
are you?
I'm fine, thank you. Thank you so much that you have the possibility to connect with us, to share your...
It's a real pleasure. I'm sorry I can't be with you in person.
So I want to ask you to open this session, then your presentation, and if some questions, and then of course, you are going to your clinic, yeah?
Yes, I'm happy to take questions afterwards, but then I'm really sorry, Eleanor, but I need to get back to the clinic. Yeah, sorry.
No.
Hopefully next time we'll be out of the pandemic and we can all be together again, which would be so nice.
Yes, I hope so, and maybe we can plan next year. How do you think the next year to make the school trophoblastic disease?
Yeah, what a wonderful idea, Eleanor. Wonderful.
Maybe in March or April. What do you think? How do you think?
When do you think the weather is going to be kind to us?
The best, of course, is June, July, but it's too busy. So maybe May.
Yeah.
May is better here.
Okay, well maybe that's what we should try and do then.
In May, okay. Next year, maybe.
Sounds like a nice plan. So, are you well and your family okay?
Yes, thank you so much.
You've managed to stay well despite the pandemic.
Yes, I had COVID, but in light form.
I'm glad to hear that.
And you, how are you?
Yeah, no, we're well. I also think I had it and had it in a very mild form, but my niece continues. She's now a year later and still has some long COVID problems. So yeah, it's very, very variable. Are you seeing much long COVID in Russia?
Just now it's plateau. So okay, now we have our colleague from Moscow. She is with us, and we can begin. Yes, we are waiting from technical service when we can begin. Через сколько можем начать?
Вы готовы, да?
Да.
Обратный отсчет даю, когда...
Dear colleagues, it is with great pleasure that I would like to welcome you at our session dedicated to the fertility preservation in cancer patients. So the possibilities of preserving pregnancy with cancer female patients, and it is very important to pay attention to cancer conditions in that. And I'm honored to introduce my co-presidium members. This is our big friend and a great professional, Professor Michael Seckl from the UK, Professor of Molecular Medicine from the Medical School Department of Surgical Cancer Surgery of the Imperial College in London. And it is my great pleasure to introduce my co-presidium member from Moscow, Professor Marina Kisilova, professor from the gynecology of the Ministry of Health Care Russia and the Mammal Advanced Hospital from Tsiva named after Gertsen. Dear colleagues, we're extending a heartfelt welcome to you, and Marina Viktorovna, may I open this conference and introduce our first presenter, Professor Michael Seckl, with his most relevant presentation, because the trophoblastic neoplasias is a growing trend now, especially in young women, and it is very important to be able to preserve fertility in such women and provide them with right medical care and treatment.
Thank you very, very much. It is a real honor and a pleasure to be with you all today. I would like to apologize that I cannot deliver my talk in Russian. Sadly, my number of words of Russian would be insufficient by a long margin to be able to do that. So I hope that the translation will work well for you all. I thought I'd like to thank the organizers for kindly inviting me, and I'd like to then just give you a brief reminder of what trophoblastic disease is. So it's a spectrum of disorders from the pre-cancerous conditions of complete and partial hydatidiform moles through to the malignant conditions of invasive mole, choriocarcinoma, and the very rare central site trophoblastic and epithelioid trophoblastic tumors. And it's well recognized that complete moles can give rise to any of these malignant forms, and that once you've got one malignant form, you can progress to another, and that choriocarcinomas and placental site trophoblastic and epithelioid trophoblastic tumors can arise after any type of pregnancy. So it could have been a term pregnancy, a miscarriage, an ectopic. Any other type of pregnancy can give rise to these types of tumors. And partial moles can also less commonly turn into the malignant forms of the disease, any of them. And more recently, we've realized that atypical placental site nodules, something that we've ignored for decades as an innocent finding on pathology, actually 10% of women with atypical placental site nodules will either already have or go on to develop placental site trophoblastic tumors or epithelioid trophoblastic tumors. So one that we can't ignore. So how can we help fertility in these women? Well, rarely for molar pregnancies, there is a repetitive form of complete mole. So the woman just keeps getting pregnant, and each time it is a complete molar pregnancy under the microscope. If you see that, it should make you think, does this woman have a rare inherited form of the disease? Because if she does, then it is almost certain she will never conceive a normal child. There are occasional exceptions to this, which we can't predict. But the vast majority of these women will just have molar pregnancies, and each time they have a complete molar pregnancy, there is a 16% risk of them getting a cancer. So is there something we can do to help their fertility? And it turns out that there is. So the disorder is in about 85% of cases due to gene mutations in NLRP7 or KHD3CL. We can't replace these genes, and in every other way the patient is normal, but what we can do is to give them an egg donor from an unaffected individual. So that egg can be then implanted, fertilized with the partner's sperm and implanted, and they can then deliver and have their own child. So that's the way out of that problem. As you know, for the vast majority of patients, apart from those who have placental site or epithelioid trophoblastic tumors, we use a scoring system to determine their treatment. And I'm not going to go into the details of this, but just to remind you that those patients who score low risk, that means they have a low risk of becoming resistant to single agent treatment, and so we'll start on a single agent. And those who score more than 6, so 7 and above, are at high risk of resistance to single agent treatment and end up needing multi-agent chemotherapy. Why is this important? Well, it will have an impact on subsequent fertility, potentially. So this just shows you a patient who's undergoing treatment for a mole that was removed, but the HCG was not going away, so this disease was persisting. So she underwent methotrexate and folinic acid therapy, and you can see the HCG normalizes rapidly. and she has a period of consolidation treatment of 6 weeks, and then that's the end of it. So most low-risk patients will be cured actually with 1 or 2 sequential single drugs and not need multi-agent therapy. Those in the high-risk group, however, need multi-agent chemotherapy, and classically, most people are now using Emico. This is etoposide, methotrexate, and actinomycin D, alternating every week with cyclophosphamide and vincristine. And we do well with treating these people. 95% will be cured, not all with Emico. 20% will either relapse or progress on Emico and need salvage treatment. And here are some of those salvage approaches, which is a lot more chemotherapy. And if the standard chemotherapy isn't enough, well, high-dose chemotherapy can be tried, and that works in about 40% of patients. There are other agents that work. Never forget, surgery can be a useful thing, and that might include a hysterectomy, which of course would be terrible for fertility. Radiotherapy is hardly used. Stereotactic maybe to brain lesions, but really nothing else. And then there are a number of new agents. And I just really want to draw your attention to the immune checkpoint inhibitors, because this is a new area of development in GTN. It looks like it's going to work in 75 to 80% of patients who have failed other therapies, including high dose. Because it's much better tolerated than high dose, it is now being used before high dose chemotherapy. And some are even advocating using it in low-risk disease, failing first-line single-agent therapy. So that could have an impact on fertility too. So let's just consider this for a moment. While methotrexate and actinomycin D don't appear to have any effect, as far as we can tell, on fertility, and there's more than 30,000 patient years of data for MTXFA, somewhat less for ACT, but it looks like they're very safe agents. Emico seems to cause a temporary menopause at the time. The body senses this is not a good time to get pregnant while you're undergoing chemotherapy, and ovarian function shuts down. But once the chemotherapy is finished, the vast majority of people, their ovaries wake up. The women where this doesn't tend to happen so well is when you're in your late 30s, early 40s. And one thing that it seems to do is to bring forward the date of your natural menopause by about 3 years. So there is an effect then with Emico, and we believe similarly with TETP, EPEMA, and the other sorts of multi-agent chemotherapies that are being used. High-dose chemotherapy, where you give so much chemotherapy you would normally kill the patient, but you save them with some stored bone marrow, seems to induce a permanent menopause in everybody that we've given it to, bar one who is restored her cycling. So high dose seems to be safest in the prepubertal setting. And of course, people at prepubertal don't get gestational trophoblastic neoplasia. What about immunotherapy? Well, why should immunotherapy work in trophoblastic disease? Well, the trophoblast, of course, even in a normal pregnancy, has 50% paternal genes, and that means it should be recognized as foreign to the immune system of the mother. So how come we're all sitting here today talking to each other? Well, the reason is that the trophoblast has multiple mechanisms to suppress the immune system, and one of which is the PD-1, PD-L1 system that you'll probably know lots about because immunotherapy is the rage. So that's one of the mechanisms by which the fetus is not rejected and the placenta is not rejected. So if you give immunotherapy to pregnant animals, they lose their pups. And similarly, we think if you were to give it to a pregnant woman, she would likely lose her pregnancy. So how long do these agents last after we've given it to patients? And that's a question that's not terribly clear, but there is some data emerging from a French study which suggests that at least a year or so after the immunotherapy ends, patients can get pregnant, and there's one patient who's now had a child. So that's promising. Hysterectomy, of course, is a pretty terminal thing in terms of fertility, although there are other things that one could imagine doing. Then there is the repeat D&C that's sometimes used in the management of molar disease to try and avoid starting chemotherapy. But every time you do this, there's a risk of bleeding, perforation, infection, and somewhat down the line, Asherman syndrome, which can affect fertility, although there are remedies for these things. So how do we avoid chemotherapy-induced infertility? Well, for methotrexate and actinomycin D, I don't think there's any action required. For Emma-Co, is there really any evidence that using an LHRH analog would avoid long-term damage to the ovaries? No, there isn't. And in fact, for multiple other chemotherapy regimens, I don't believe there's any really good evidence that these things work, but a lot of doctors like to use them. Egg harvesting before you start the chemotherapy is a lovely idea, but this is a fast-growing cancer, so you don't really have time to do it, and HCG itself may be a growth factor for the tumor, so you wouldn't be wanting to give people HCG around egg harvesting, although you don't have to do that. Cutting out a piece of ovary and freezing it in the freezer might be something you could do, but since their fertility is so good anyway after Emma-Co, you might impair some of that because of scarring around the ovary from doing it. So probably not a necessary intervention. High-dose chemotherapy, I think the answer is if you can avoid it and replace it with immunotherapy and just wait a bit of time before you allow the patient to get pregnant to allow the antibodies to have disappeared sufficiently from the system. What about placental site trophoblastic tumours and epithelioid trophoblastic tumours? Well, here the mainstay of treatment is hysterectomy. And focal resection is often talked about, and we'll come on to that briefly in a moment. Chemotherapy, if it's metastatic disease, is the other mainstay of treatment, followed by surgery to remove the primary sites of disease, including a hysterectomy. And of course, if your disease presents more than 48 months from the causative pregnancy, then you really have a poor outcome, even if it's early stage disease. So it's hysterectomy plus intensive treatment. How could we preserve fertility in this setting? Well, obviously, could you avoid the hysterectomy for localized disease? Could you consider giving neoadjuvant chemo and avoiding giving a hysterectomy altogether? We've certainly seen in patients where we have given chemo before the hysterectomy, come to do the hysterectomy, we can't find any evidence of disease left. So that suggests that this could be a viable option. You could give neoadjuvant chemo and follow that with focal surgery. Maybe that's something that's worth considering. You could consider focal surgery alone for a focal lesion, particularly if it's within 48 months of the causative pregnancy. And then you could do a hysterectomy, which is the classical management, but then offer some years later the possibility of a womb transplant, which is on the horizon and being done in certain countries now. And then, of course, there's always the possibility of egg donation from your own ovaries and using a surrogate mother to have the child for you. And in metastatic disease, what fertility conservation could you consider? It's very difficult to imagine other than trying not to remove the uterus at the end after aggressive chemotherapy and possibly immunotherapy. And the main message I want to give you is that all of these approaches should be viewed as experimental. We've tried some of these, so focal resections, for example, and the problem with that is that you end up in some cases where you think you've done the job fine, you've taken out the focus of disease, clear resection margins, and then some months later, the HCG goes up, you can't see anything on scan, and then you do a hysterectomy, and you find multifocal bits of PSTT or ETT scattered throughout the uterus, which you just can't see on scan. So you've got to counsel these patients very carefully. What about APSN, that odd thing that I mentioned that's new to the spectrum. Well, this is difficult. This is how we manage it with a one-stop clinic where we get all the imaging done. We then organize genetics to look for the causative pregnancy. If there are no metastases, the family is complete, we recommend a hysterectomy. No need to try and preserve fertility. If there's no cancer, they can be discharged. If we find cancer, then it needs to be managed as such. If the patient wants children and there are no METs, the APSN is less versus greater than 4 years from last causative pregnancy needs to be discussed with the patient, because of course that has an impact on the potential prognosis of a PSTT or ETT. So there's counselling and surveillance for those patients. And if the patient's already got METs, then it's into investigation of all of this and treatment as appropriate. So summary, low risk GTN, single agents, no problem, and try and avoid a hysterectomy. High risk GTN, avoid high dose chemotherapy, avoid treating for more than 6 months. PST and ETT, all fertility sparing approaches are experimental. There are many questions that remain, amongst which is how do we figure out what's a good and a bad APSN, where the effects of immunotherapy are in terms of fertility preservation. We still don't fully understand that. So there are lots of questions. Thank you for listening to me. This is just a very brief overview.
Спасибо большое, профессор Секл, за...
Thank you very much, Professor Seckel, for such a comprehensive scope that you have presented for trophoblastic diseases in your presentation. And despite the limit of time that we have, and thank you for underlining that despite very common and metastatic and complicated invariations of trophoblastic diseases, fertility in such patients can be preserved. Can I ask a question to you? After what period of time you allow such patients to get pregnant upon they have been cured of the trophoblastic disease? After what period of time they can safely get pregnant? And if you reject this possibility, what are the methods to protect themselves from undesirable pregnancy if they need to use these methods?
Yeah, so that's a great question. So our standard advice is to wait a year after completing chemotherapy. But clearly, many of these women who are in their 30s are worried about their biological clock. And so we tell them that we've had 500 women who have ignored this advice and got pregnant in the first year, some of them having had low-risk treatment and some of them having had high-risk chemotherapy. And what happens to them? Well, fortunately, the babies that were born all looked normal, so none of them came out looking abnormal. There was the usual expected miscarriage rate, there was the expected second molar pregnancy rate, and there was no increased risk in the rate of relapse, which was one of our fears, was that getting pregnant early might increase the relapse rate. In fact, far from it. The relapse rate actually looks slightly lower in the women who get pregnant in the first year. There was one case, though, who did relapse during her pregnancy, which we, of course, couldn't pick up early because the pregnancy makes HCG, so you've got no useful biomarker anymore, or at least it's relatively not so useful. And when she presented, she was already coughing up blood from her lung metastases, and so she needed emergency chemotherapy. Her baby ended up coming out early, but fortunately, both she and her baby did very, very well. So it was a happy ending, but it caused a lot of stress at the time. And so then it becomes an adult decision for the patient whether she wants to go ahead and have a pregnancy early or not. And I don't stop people from doing it, it's up to them. But our standard advice, if they're very young, is wait a year. They've got nothing to lose. There's no biological clock problem, so they can wait. And in terms of hormone contraception, they can use any form of contraception they like, no problem.
Спасибо, спасибо большое.
Thank you very much, Michael.
Микрофон включите, Марина Викторовна. Не слышно почему-то.
Она не может быть не выбрала, она выбрала русский канал. Русский нажала.
Русский канал, там внизу в планке глобус. Нажать.
So the speaker needs to change the channel. She needs to speak into the Russian channel, and she's speaking into a different one. Hence, we cannot hear what she's saying. Just a moment of technical nuisance.
Сейчас, подождите, переводчики, не переводите. Марина Викторовна, там есть внизу глобус, на него нажать и выбрать русский канал. Маленький глобус, видите? Все, переводчик. Да, теперь хорошо, да, Марина.
So, can we ask questions now? Yes. Thank you very much for this very detailed overview of the disease. In the UK, cannot hear what she's saying because she gets interrupted all the time. I can just get the endings and beginnings of the word.
Скажите, пожалуйста, в Великобритании методы эффективного сохранения до начала
So I still cannot get the question. So, are there any methods of just early preservation methods before just the person gets pregnant or something like that? It's just.
I'm not some interpretation difficulty there. I'm so sorry.
пожалуйста, может быть, из вашего родителей слышно?
Мне тоже, Марина Викторовна, прерывисто
Слышно.
Переводчики пока не переводите. Скажите по-русски вопрос, Марина Викторовна.
Just a moment, they're figuring out because no one can hear what she's asking.
Выбрали русский, выключите сигнальный звук. Теперь слышно?
Да, давайте попробуем.
Будьте добры, скажите, пожалуйста, существуют ли в Великобритании методы сохранения генетического материала до начала лечения?
So, are there any methods in the UK to preserve the genetic material before just the chemotherapy is appointed? And what are these? And what are the legal foundations and legal framework of using surrogate motherhood alternative for such patients, cancer patients?
So yeah, it's a very good question about the legalities of using how do you access egg harvesting and how do you access getting egg donation done? You're quite right that different countries have different rules about this, and the rules actually change. So when we first started doing this, our patients had to go to Spain actually to collect egg donors. That's no longer needed, but that had to happen at one stage. So the rules do change, and I can't comment on how things work in Russia, but some patients have had to travel in order to get their egg donation done for a surrogate pregnancy or to find a surrogate mother. But in the UK, we can now mostly do it. So most of these things are now available to us. So, for example, if we want to freeze a bit of ovary and wake that up in a patient, even though this is still viewed as experimental, we can do it. Transplantation of the womb, which I mentioned, is still going through its final process of approval in the UK, but there is already a centre set up to do it. And I believe we're planning our first uterine transplant in the next few months. But on the other hand, this is available in other parts of the world. So you're right to raise this as an important question.
Спасибо большое. Спасибо.
Thank you very much. Thank you. May I thank you, Michael, once again. Thank you, Maria Viktorovna. I would like to call upon the next presenter. She was going to speak about the diagnostic imaging standards used during pregnancy in Mashenko, and the lead scientist of the Institute of Medical Education of Almazov Center.
Dear colleagues, Yelena, I appreciate having been invited to this fourth Innovation Forum, and now I would like to discuss the opportunities of X-ray diagnostics and to unveil fears to use it for pregnant women. Imaging for pregnant women also is very important, mindful of the oncological disease. We have to protect women from adverse effects of that, taking on board state-of-the-art methods of diagnostics in cases when they are absolutely needed. A pregnant woman is an equation with lots of unknown things, and we had to take into account all the all the specific characteristics and mindful of the future. As to the current trends in the diagnostics for prenatal practice, about the fears, about the method of diagnostics and different algorithms of diagnostics in pregnancy. The history of prenatal diagnostics is the era of conventional X-ray diagnostics and comprehensive multi-model one for the obstetrician and oncologist. They use ultrasound, computer tomography, MRI, and radionuclide diagnostics. There are two big groups of methods. First, methods with ionizing irradiation, X-ray, CT, radionuclide diagnostics, and without ionizing radiation. This is our favorite method, ultrasound and MRI. As to the ultrasound and MRI, obstetricians and oncologists and gynecologists are not fearful of that. But as to X-ray diagnostics, radionuclide diagnostics, and CT require interdisciplinary efforts of radiation diagnostics and medical physicists. Nowadays, ionizing irradiation methods during pregnancy has been increased. It's necessary for us to control the amount of methods we use in order to avoid the unsubstantiated impact of ionizing irradiation upon the pregnant woman and the fetus. We're fearful that the impact of ionizing irradiation could have lots of adverse effects, which depends on how strong this irradiation is, and there is a determined effect that is the damage or loss of cells throughout irradiation under high doses, stochastic effects, transformation of cells into tumor cells, which might be evolving at irradiation by small doses is only a third. Variant is the combination of those effects which could evolve when the fetus is also impacted by radiation in prenatal period intrauterally. Here you can see consolidated data on assumed determined effect, which could be intrauterally induced towards the fetus. Those dependent and sensitive to adverse impacts such as self-abortion, failures in development, mental retardation are in the period from 3rd to 18th week of gestation, when all these radiation diagnostics are not undertaken by us unless there are very ground reasons for that. Also, there are assumptions that there are some stochastic risks around, but unfortunately we don't have very exact data. The risk of developmental malignant tumors in neonates impacted by ionizing irradiation is 0.1% per each 10 microgray, and the of irradiation and the potential risks induced by ionizing irradiation in second and third terms and in the first trimester as well are comparable to neonates, but those assessments nowadays are not exact. In future, we need more R&D related to that. Another method after ultrasound, which is in compliance with all the safety requirements, is MRI. This is a relatively safe method of diagnostics. Why relatively safe? Because when we do MRI, also there are some risks. First of all, risks from the influence of magnetic field, when all the ferromagnetic objects could be injuring agents, and pacing, the work of pacers can also be impaired, and before referring to the study, we exclude all the counterindications for such a pregnant woman for MRI. And second risk factors are risks from switching gradient coils from tomographer. They create very high acoustic noise. We're afraid of that, but we know how to combat with that. It's controlled risk now. And thirdly, most dangerous from the standpoint of biological impact is the risk from radio frequency fields impact, when there is the overheated tissue of mother and fetus. We're fearful of that, but it's reassuring that now we use green risk-free corridor with compliance with all the safety measures when we do this kind of studying. Major principle is all the diagnostics done for outpatients are prohibited to use in inpatient clinics. There should be a continuity of all those things. Unfortunately, this principle sometimes falls flat to some reasons. We will not discuss that now, but this is the problem, and we have to deal with that. Next, guiding principle of radiation safety is about using the lowest dose at the studies, LR principle, as low as possible, and we specialists have to avoid even very low doses of irradiation unless it gives unless it's very important for the pregnant, and so it should be as low as reasonable and achievable, and the application on indications only for MRI. And then let's figure out something else. What kind of pathology is the reason you refer the patient to us? First of all, indications are split into three groups: non-obstetrician pathology, uteral pathologies, and pathologies of extrafetal structures. For non-obstructed, sometimes it's possible to use but if it's non-obstetrician pathology, you'll require the plethora of methods of diagnostics, especially patients with oncologies. After you identify the indications, you as the doctor, together with us, radiation diagnostics, have to undergo a three-stage process of substantiation of the method of diagnostics, responding to the following questions. First of all, which methods of the radiation diagnostics would be most informative for the patient? The application of exactly this method of diagnostic should bring more advantages than damage. It's odds ratio you should undergo. Then which methods of diagnosis should be there? It should be in the clinical guidelines, guidelines for specific methods of diagnostics under assumed or established diagnosis. And thirdly, which are the peculiar characteristics of the selected study? In this case, it's personalized. You should look at the patient's history, disease history, and maybe there are counterindications to some methods. And X-ray specialist works with you in assessing the substantiation of indication, or might suggest some other method or methodology which should be responding to your questions and clinical tasks. So there should be multidisciplinary approach for that. You should interact. And I'm about to finish, and mindful of everything I said, it's sort of stock taking or a takeaway from you for you. I put together which is split in 4 parts. First, don't indicate studies unless you need them for the tactics of management of the pregnant. Diagnostics should follow the indications, but you should not postpone the indication of the studies of the patient, which are necessary for us to follow up as well and to manage. Diagnostics, imaging has got low risks for fetus. Risk is there. We're aware of that. We remember, but it's a low risk. It's below the factors which could be related to damage of fetus if you do nothing. And you should compare the risks of diagnostic imaging or its absence. If the pregnant woman might die because of oncology, why should you think about the risks for the future baby if the baby will die together with my mother? So the patient, the pregnant, and the fetus is also in the center of our decisions. Whatever method we use, it should be clinical substantiated. There should be multidisciplinary approach towards substantiation. We should assess odds ratio always in the category of pregnancy with oncologies. Risks are always higher in this odds ratio. I don't call upon you to get from fears and phobias to another continuum. Don't go overboard with that, but you should get in contact with us doing the diagnostics to find the best way of diagnostics, which would the best and which would be most safe for specific category of patient and fetus. Moreover, when we use ionizing irradiation, we should always use LR principle of radiation safety. And if such a pregnant comes along, and we should do all those studies, we should do it with specialists who know everything about the guidelines and the protocols in order to be safe. Here is my contact information. I'm open for a dialogue. If you have questions after the conference or wherever, whenever, You may write to my email or use messengers. Thank you very much. If there are questions, I'll take them gladly. Thank you very much. Thank you so much. Thank you, Irina. And you've been within the time. And thank you for your presentation. It's very important for us clinicians to hear from you, the specialists in radio diagnostics, what they want from us, which should be our requirements as well, and what you should do for us to be adequate with your radio diagnostics. So I have a question. Oftentimes in malignant tumors in women, we use MRI, CT with enhancement, and sometimes we do it without enhancement. And so how this enhancement, should we do enhancement during pregnancy? Thank you. That's very topical. That's very important. According to all the guidelines, enhancement, contrast, pharma should be done there only in line with protocols. It is a special category, oncological pregnant women, and whenever it's necessary, if it is required, if we assess odds ratio and we say that we cannot do anything without enhancement, so we use contrast, we use enhancement, but it's not for each pregnant we'll use enhancement. And we have got broad opportunities, MRI, lots of methods and methodologies quite enabling, so we might not use enhancement. But if it's CT, if it's some urgent conditions, so the contrast should be introduced intravenously. When there are abnormalities of the fetus, we don't use enhancement. Thank you so much, Irina. Thank you, Marina. Dear colleagues, very interesting presentations. Next speaker will be Professor Elena Ulrich with a presentation on standards of management of oncological patients pregnant during pregnancy.
Thank you. Can I have my presentation put on, please?
Глубоко уважаемые коллеги,
Dear colleagues, may I proceed to present my paper about the standards of managing cancer patients during their pregnancy. And here we have a lot of guidelines by European oncogynecologists, for example, National Association of American Oncologists, European Association of Chemotherapists, and for the Russian Federation, the major guidelines are the recommendations by associations of Russian oncologists and the Russian Association of Chemotherapists. Also, there are other guidelines. However, the latter ones, the Russian recommendations, Russian guidelines, include recommendations on the treatment of onconeoplasia with different localization points. As to the pregnancy cases, we are restricted by the guidelines that bring together, summarize the recommendations on managing such patients, basing on the international experience, on expertise of the institutions that are entrusted with treating such patients. As to the Russian recommendations, when the cancer, when the tumor is combined with pregnancy, we have some guidelines for obstetricians and gynecologists, just the guidelines for artificial induced abortions, and there are it is class 2 neoplasias, just the cases that require chemotherapy or radiation therapy for just pelvis, and it is to be in all other cases the issue of artificial abortion is to be decided by a concilium of physicians. So these are the federal legislation acts, and some of them have been adopted, and some are still on at the revision stage, and we are expecting it to be adopted quite soon. And when it is, so the list of medical indications for induced pregnancy is just malignant neoplasia of the women's sex bodies and others. So, and here are the guidelines that contain recommendations for all the major localizations of tumors, and in combinations of cancer plus pregnancy. We only have a mention made for trophoblastic tumors that were brilliantly overviewed by Professor Michael Seckel, but he also mentioned treatment of young women targeted at preserving fertility. And in my presentation, I'm going to focus on this case when it has the partial node. And we need a multidisciplinary approach to be ensured, and a very careful and thorough examination of such patients where we see such a rare pathology combined, trophoblastic disease combined with pregnancy. We need to exclude the defects of the development of the fetus. We need to identify the normal karyotype of the fetus. There should be moderate obstetrician risk and other factors taken into account. In our Almazov Center, we have encountered such situations in multiple cases. It is important to ensure the dynamic observation, just follow-up of such patients during their pregnancy and delivery. The trophoblastic neoplasias combined with pregnancy cases, we had 4. We failed to preserve pregnancy in 2 cases, and while in the other 2, the delivery were quite successful. So one of such successful cases is a 32-year-old patient who was treated in Almazov Center, and together with GTN, that was diagnosed during her pregnancy, so the defects of the fetus development were excluded. You can see it on the slides. So the prenatal invasive diagnosing method was used to assess the karyotype. There were no defects detected, and there was no invasion identified in the MRI, and there was the lung X-ray done to identify the distant mets. There were no identified, and the delivery happened before the time, and in a situation which it was not possible to prolong the pregnancy, and the pre-time delivery happened on the 28th week, but there were no abnormalities in the newly born child except for anemia detected, and after the treatment by our neonatologist. The newly born baby is quite good. The mother was subject to the dynamic observation, and there was a relapse of the tumor to the lung. It was just ACG the growth. So the dynamics of this marker, as it was mentioned by Professor Seko, helps us to diagnose and observe the patient. So the patient was subject to the CT with contrast, which is very important for diagnosing, and just the lung mets were identified. However, it was diagnosed at an early stage, and she underwent the chemotherapy. Trophoblastic neoplasias can change stages during the treatment. However, it was still low risk category, and the standard chemotherapy was appointed related to the risk group. And there was an improvement with the lungs, so now she is in a remission. She is healthy, and the child is healthy, and her womb was preserved, and they are being observed in a dynamic observation model. Here, malignant tumors of ovaries during the pregnancies are the most common ones, and just the uterus neck as well. As to this condition, it is an asymptomal condition before and after and during the pregnancy. However, they are diagnosed quite early, at an early stage during the screening processes, and these neoplasias are easily identified. Dominating are germinogenous and epithelial tumors, and it is well demonstrated by our European counterparts. So the non-epithelial are more common. Over the last 18 months, the majority of such malignant ovarian tumor patients were epithelial, high-grade, low-grade ovarian cancer, and non-epithelial case was only one of them. The major diagnostic methods are ultrasonic examination and MRI, which the previous speaker mentioned, and it is allowed during the pregnancy in such cases. And our MRI experts are quite experienced in diagnosing such patients, and they can do it without using contrast, providing for reliable expertise that we can use to further determine the management strategy. As to CA125 marker, which is very successfully used for additional diagnostics and monitoring, it may not be so informative during the pregnancy stage, but still is quite useful, but not fully reliable. So the surgery should be performed at any stage of the ovarian cancer, and if we can do it in a laparoscopic way, and the institutional surgery decides upon using this method, it is performed, and we are not, if we are not sure whether it's a malignant or benign tumor, and if we do cystectomy, and there's going to be just an outflow of the cyst, we will find the patient moving on to stage 1C. So cystectomy is more desirable. Otherwise, we are putting the life of the mother and child at risk. However, these are the major recommendations. So it's a patient, age 33. It was operated on on the 17th week of pregnancy. There was a laparoscopic. It was a complete adnexectomy, a biopsy of the collateral ovary, and the final low-grade ovarian cancer was determined after the histological study. So it was 1A stage, low-grade pregnancy. No actions were needed. The pregnancy was prolonged, and we understand that no tumor cells got into the abdomen. So the pregnancy continued. It was the second delivery on the 36th, 37th weeks. Unfortunately, so there was she had to undergo a cesarean cut because there was a preterm placenta just coming off, and it was quite a successful operation. So there was so suspicious bits underwent biopsy, and fortunately no bad things were discovered, no tumor elements detected, and both the woman and the child are good and observed. So when a woman wants to preserve her pregnancy and has ovarian cancer, so then she has to, if it's a low-grade stage, she undergoes a surgery. But if it's a high-grade and the stage is different, so the chemotherapy is indicated. So it starts in the second semester, because during the beginning period of pregnancy it is forbidden. And you can see the scheme of chemotherapy. They are now identical to non-pregnancy cases. Here, there is a requirement to finish chemotherapy 3 weeks before the delivery, and it is very important to resume chemotherapy as soon as possible after the delivery, which was done in this particular case with a 34-year patient. She was operated on a different institution, and an ovarian cancer was identified, and there were some cells detected in the local fluid. So there was she was diagnosed to have high-grade ovarian cancer, and she wanted to preserve her pregnancy. And she had 4 courses of chemotherapy, and she had a cesarean cut, and you can see one suspicious bit in the upper just hind part of it. And we staged this 1C3 according to the bit. She was closer to 2C tumor grade, and we needed to identify it clearly and thoroughly. As a result of a duly started chemotherapy and some radical treatment of dissection of the woman, just peritendectomy. So the histologies gave us quite promising findings. She is continuing chemotherapy. She has had 6 courses, and both the child and the mother are good, and so diagnosing ovarian cancer during the pregnancy through ultrasonic test and MRI, and adjuvant chemotherapy, if it is necessary, it should be performed, and the surgery is recommended once the cancer is determined. So here we can see the recommendations of the Russian and European Society of Gynecological Oncology. And here we need to identify the lymph nodes, cervical cancer diagnosing. It may be MRI diagnostic, and histology is the verification is a preferred strategy here when we need to assess the lymph nodes. However, MRI gives us quite reliable picture. If we have any suspicions that the nodes are affected, it brings the patient on to stage 3, and here the prognosis is worse. We need to start the treatment as early as possible to preserve her health and just to terminate her pregnancy and provide full-scale treatment. If the tumor is of a larger size and if the lymph nodes are affected, we use the same strategy. But if lymph nodes prove negative, then the tumor and the tumor is of a large size and the patient wants to preserve pregnancy, we can prolong it. However, we need to appoint chemotherapy during the pregnancy. So this is a patient 34 years of age. She was not interested in prolonging her pregnancy, 1B2 stage. So on the 6-week radical hysterectomy was performed. So it's a cervical cancer 3B. PT2A2 and YMOG2 was diagnosed. She has a 1-year-old child, and she underwent a radical treatment. So the next pregnancy happened after 18 months, and it was what we diagnosed. She was not, hence, interested in prolonging the pregnancy, and she is under radiation therapy at the moment. However, there are no standard and easy situations both in oncology and gynecology spheres. And as an illustration, I would like to present this pregnant patient. She approached us on the 23rd week of pregnancy, on the big cervical tumor over 4 millimeters large, and there were lymph nodes affected. According to MRI, it was she was diagnosed as having this stage 3, and it was a flat cell cervical cancer. She wanted to preserve pregnancy, and she underwent chemotherapy while she was still pregnant. We see the tumor regressing. Before it was quite bad, and after chemotherapy it got better, and the lymph node decreased, and 3 courses of chemotherapy were conducted, and a laparotomy and cesarean cut were performed with a radical hysterectomy. 8 the score Apgar scale child was born, and they had no health problems detected. The mother underwent radical hysterectomy to treat the cervical cancer. We have analyzed the Almazov's experience of the last 5 years in terms of diagnosing malignant tumors during pregnancy, and we have diagnosed 195 pregnant women with such a diagnosis in 152. There was a surgery, and in the remaining cases, the chemotherapy was appointed. Hemoblastosis that were diagnosed in the second trimester of pregnancy, and the treatment was started at an early pregnancy case. As to the solid tumors, the treatment was started during the pregnancy, and the thorax cancer patients, which we had a lot, account for the biggest part in this pie diagram. Their treatment was postponed for after pregnancy period, and for all the other patients, the treatment was appointed during the pregnancy. In 70% cases, so that there were just full-term deliveries, and most of the neonates were full-term ones, according to this table. To sum up, in treating tumor patients, it is important to rely upon a multidisciplinary team diagnosing and staging to provide good healthcare treatment. It depends on the stage of the tumor and histological type, the term of pregnancy, the condition of the fetus, and the wish of the patient to preserve pregnancy. Thank you. Thank you for your wonderful presentation. Are there any questions to the presenter? Can you hear us? We are overusing our time frame already. Maybe we could put off questions and answers for the final part of the session. And now I would like to call upon Professor, Doctor of Medicine, Professor of Gynecology's Department of the and head of the innovative approaches from CIBO, Marina Kiselyova, who will speak about oncofertility and contemporary reality.
Thank you very much. So you can see us. You should share your screen. Just bear with me. I'll give it another try. There is no screen shared yet.
Почему не видно?
Все включила. Colleagues, so I'll have the presentation about the realities of the situation in Russian Federation about resolving the problem of oncofertility. Year in, year out, there is a growing number of oncological patients of fertility age. First of all, it's BC diagnosis, then gastrointestinal tumors. As to the reproductive age oncological patients, first of all, it's breast cancer and cervical cancer among young patients under 35. BC is up to 16%. According to Eurostat report, 40% of women in EU. By the same token, mindful of the fact that those oncological patients display oncological disease at age up to 35, of course, there are reproductive fertility losses. Apart from that, I would like to say that in all the countries, European and Russian alike, the number of women who would like to become pregnant by the same token have been growing. According to Eurostat, 40% of women in EU give birth to first baby at age of 39. So it's the targeted group with higher risk of oncological disease. And it has been growing. Major methods of sparing fertility are embryological technologies. First of all, cryopreservation of mature and immature oocytes and cryoconservation of ovaries tissue. Guidelines were published in 2020, and they maintained that it's necessary to get consultations on fertility in all young women of reproductive age. And also, it was mentioned even today that cryopreservation of ovarian tissue is not an experimental procedure. The major legal implications in Russian Federation are based on new decree on the use of the art. So major indications for cryoconservation of biological material is sparing fertility prior to radiation therapy. Major indications are age and good ovarian reserve. About the level of PSK, LH, estrogen, histological type, anti-Muller hormone amount, and also genotoxicity and histological type, stages of disease, and the prognosis for survival, and mostly it's based on the willingness of a woman to preserve her genetic material. And all those technologies have been developed around the world, but unfortunately in oncological patients, we try to use natural cycle. We repeatedly said that we studied this reserve before the treatment in 47% of patients prior to treatment. Already ovarian reserve is impaired and reduced. Maybe due to gonadotoxic effect, major drug used for stimulation in our patients, as to the different variations which is allowed is letrozole. Here you can see a schematic of letrozole. From the second day of the cycle, gonadotropions from the fourth day of the cycle, and so on. So on the one hand, it's fertilized egg, and in one case there was no normal egg. I would like to dwell on the state-of-the-art technology of cryoconservation because on oncological patients of reproductive age, it's not possible for us sometimes to get genetic materials as oocytes, and we use cryoconservation of ovarian tissue. 2012, 20 American Society of Reproductive Medicine classified this procedure of cryoconservation not as experiment one, or the one which can be used in clinical practice. And here we can see the logistics of this preservation of ovarian tissue around the world. There are lots of publications about neonates born, more than 40 and up to 100. But this data is not quite valid yet, so we do not dwell on that. Immature oocytes are also used, but the results are not quite promising as yet. We spoke about our legal frameworks as well. After autotransplantation of vitrified ovarian tissue in our patients after gonadotoxin treatment, in 85% of the women, menstrual cycle was restored. In 43% of patients, follicular function was restored and embryos were received. A group of our colleagues from Texas, US, they also refer to cryoconservation method of ovarian tissue. They think that long-term restoration of endocrinal function makes life much easier for young oncological women. And we have good database, and there are very big amounts of genetic materials as well. The bank of materials, mostly it's breast cancer and also cervical cancer and other oncological diseases. The highest age of patients is 21 to 30 years of age. Here you can see major types of genetic materials stored in our bank, but most frequently used is breast cancer, that oncological disease which also is more typical for women of reproductive age. According to Oncological Service of Russian Federation, we followed up the fate of a very big amount of patients, 1,600 patients at age 25 to 46 years of age, with identified BC over the period since 2008 and 2017, and 120 were just introduced into the study. Most of them restored their reproductive function. We now follow up more than 1,400 patients. As to male patients, here are the samples of sperm we store for more than 5 years, and I would like to underscore the reality of all that. Unfortunately, 24% of patients asked us to utilize the sperm which is stored in our bank. 76 say yes, you can use our sperm, later on you store it. And as to those who are participated in ART, there are only 15%. As to overseas studies, it's in vitro activation, no technology. The activation of follicular and multi-step systems of cultivation of ovarian follicles. It's also gene modifications, 3D printers for printing ovaries. It's only an experiment, but it's very interesting to test this development and try it on people as well. First, it was mice model used for that. It's the creation of new ovaries for patients. That's what's used here, 3D bioprinting, but all those are only experiments. Stem cells used by the same token, a sort of experimental technology yet, which is not yet clinically developed further. Mindful of the realities of today, the problem of fertility, we would like to underscore the fact that is the initiation of using artificial reproductive technologies or art here. And we would like to refer to the recommendations of European Association of Reproduction in 2019 with the date of Danish trial with more than 600 women which used art. And according to the data of this trial, development of cancer was not associated to the use of art. Same was done in the studies of our Danish colleagues between 2005 and 2004 and 2015. As to the increased risks of the development of oncological study used after the use of art, this big overview was published by the Institute of Reproductive Medicine of WHO. more than 8,600 women were studied, and the number of pathological diseases was very small. Oncological disease in children after art, 25 cohort trials case control in Denmark and very low risk of disease in babies after art. Case control again, and similar trials were published in 2015, 2016. So they have never traced the use of art and the development of cancer. And also they didn't confirm the risk of development of ovarian cancer for women who underwent art. So these are the realities of today. So pregnancy of oncological patients after adequate treatment is possible irrespective of histological type of tumor. The likelihood of the aggravation after chemotherapy has been studying cryoconservation of fetus and all embryos of all sites is the standard option for conservation of fertility. Fertility consolation, fertility sparing in oncological patients now has become quite routine and commonplace, and conventional procedure is done within the regulating orders. The organization of consultation should be done in presence of different specialists, reproductologist, and maybe medical consilium should be there. Now, Center of Research of Radiology, reproductologists consults the patients, and you can be referred to that if it's oncological disease of different type, or they should be radiotherapy. For you, you should visit our center as well. Thank you very much for your attention. Thank you. Thank you, Marina, for a fabulous presentation. This is very good for practitioners to use all that. Are there any questions? Unmute your mic, please. Can you hear us? Marina, I have a question. When it's breast cancer, do you frequently use letrozole? Yes, we use letrozole. Yes, first we, of course, we look at this reserve. And so, if it's not possible to take the egg in the natural conditions, we use letrozole. And unfortunately, this epithelial reserve was very low prior to the beginning of the treatment, so it was not possible. And we used letrozole. Well, if there are highly stimulated ovaries, do you use agonists of releasing factors after you take the egg? Do you use the gonadotropin releasing factor agonists if there are overstimulated ovaries in order to obtain genetic materials? No, in order to reduce the risks if it's done against the background of radiotherapy in breast cancer patients. No, we don't use that. So you're not fearful that ovaries must break or whatever after stimulation, ovarian stimulation. We don't use letrozole, but as to the complex treatment of BC, of course, we use Zoladex and other medical drugs in young patients. It's not about breast cancer treatment, but as a manipulation. No, we don't. We don't use them. So there are different methodologies in different reproductologists. As to the standard of management of oncological patients with BC in order to obtain genetic materials, we don't have it. We only have those medical drugs which are not banned from use to stimulate ovulation and obtain genetic material. But as to the logistics of the development of medical drugs, no. But nonetheless, I would like to say that now we are putting together the guidelines of the Russian Oncomammologist Society and the Center of the Obstetrics and Gynecology is also participating in that, and we discussed that in the last meeting. And I think that shortly all those guidelines will be published. Thank you. As to your practice, what percentage of women was using those preserved oocytes? Unfortunately, almost none of them. This is our reality. And patients after treatment from cancer, there are some males and females come up to us, but according to American colleagues, to Rita Woodrow, the percent out there for them is only 5 or 7. But I don't think it's because there are counterindications for our patients to get pregnant after treatment, but simply we're at the age when not all the patients know that, not all the patients are aware that that is possible after the treatment, oncological treatment. Oftentimes, it was sort of set in stone that cancer in pregnancy after chemotherapy, after treatment, is not possible, period. And nowadays, thanks to the wonderful efforts of the oncologists and all those R&Ds, and the fact that we're not sitting on our hands but making great progress. There are lots of groundbreaking technologies, but there are lots of tripwires as well around the way, because the ubiquitous use of this technology might impair the situation, and there will be an upswing of oncological diseases in young patients. Because there could be recurrences. But now there are technologies of stimulations irrespective of the cycle. Could that help Nowadays, we are not pegged or tied to the menstrual cycle phase, so we might not postpone, we may not postpone cancer treatment, and we might receive those oocyte treatment, oocyte cells before that event in 2001, when we were officially allowed to use all those technologies and art in the program. In our program. Yes, by the same token, I would like to highlight the fact that Marina should be given credit for this great thing, the ability to use art in oncological patients. And Marina, correct me if I'm wrong, until 2012, there were counterindications to use art. First of all, art was banned for oncological patients. After 2012, this opportunity came along so that for oncological patients it's possible to use artificial reproductive technologies with hyperstimulation, ovarian hyperstimulation. It's so gratifying that Marina is here with us and telling us about those wonderful things. If there are more questions, I don't know, maybe Marina will stay on for the discussion, and after Svetlana's presentation, we'll discuss it more. And then I would like to give the floor to Doctor of Medical Sciences Svetlana Khokhlova, head of the oncological department of anti-tumor drug therapy of the center named after Kulakov from Moscow. And today, Svetlana Viktorovna is with us. Marina, can you stop sharing your screen?
Good afternoon, dear colleagues. It is very good that we are raising this issue today, because it is very often that we hear from oncologists who prevent of patients to get pregnant because they are waiting for the chemotherapy. And fortunately, due to our joint efforts, discussions in such congresses and symposia, the situation is changing for the better. We just heard about the techniques of conservation of embryos and oocytes that can be used for cancer patients. Since I'm a chemotherapist, I would like to speak about the methods and techniques to protect ovaries while using chemotherapy. We all know very well that chemotherapy produces early and later menopause, and in young patients, and it is endangering fertility and quality of life, finally, which is very important for such patients. Because it increases depressive states and cognitive and risk of skeletal breakages and diabetes mellitus and CAD. And the early menopause is, of course, undesirable. And now on to the mechanism of chemotherapy action. The process of oocyte maturity goes through many different stages, as you can see on the scheme. And the issues of maturation at each stage chemotherapy can have its effect both directly affecting prenatal oocytes as well as at the stromal damage. Targeted therapy can be used. It can destroy vessel beds, and finally it affects the eggs. So we know about the early and late toxic effects. Early effects, it's a transient loss of menstruation, and which is getting back to normal after some time. And we can just use it at an early stage. As for the later stage, we have the complete amenorrhea, and here chemotherapy destroys the primary follicles, and this is the most dangerous part of it for that of chemotherapy that affects the primary oocytes. Today we have reliable data showing that chemotherapy just acts on different stages, and also affects all stages of oocyte maturation and development. Its direct action is targeted at destroying the structure of the DNA, so all the agents that affect DNA structure oscillating. But it is not so crucial, since there are systems, techniques to restore DNA and its defects. Then the follicle can restore as well. Oncopatients sometimes lack they have some breakages in the homological recombination, and just DNA repair fails. And just we have some challenges with restoration of oocytes. We have clinical data that such patients will have a higher risk of the death of oocytes in the mutation BRCA1/2 case. We have studied the behavior of oocytes death post-chemo, and we see that such patients has demonstrated a higher oocyte death percentage, and thus they are in a greater, higher risk group. The high risk, it's the alkaline agents. They induce the inhibition of the DNA synthesis and just breakages and disorders in DNA and others. And finally, the P63 mediated death of primordial follicles. The mild risk inhibits replication of DNA, special toxic effect on the immature follicles has not been detected. So we see the effect on the hair follicles, on the marrow and nail beds. However, they get restored quite quickly as to the ovary. This is the anomaly body that fails to regenerate, and it is very important since it's very dangerous to minimize the adverse effect of chemotherapy on a follicle. So just it's important to preserve the oocytes which were just primordial when during the conception and the pregnancy and birth. Say they start maturating and developing during these processes. A lot depends on the condition of the woman, on chemotherapy, on cytostatic activity and others. Chemotherapy, not in terms of the cytostatics which are affecting DNA. They affect different stages and ways of the follicle development. What is dangerous here? And you can see the agents, the drugs and their action here on this pie diagram. The most dangerous and hazardous are the agents in this. So they affect the follicle, and all other cytostatics are less toxic, and they have transient effect. New drugs, targeted drugs, will induce the growth of the blood vessels and oocytes. As to immunotherapy, we have no data here. However, theoretically, it should not be expected to have an adverse effect on the oocytes. I think that the modern drug agents should be better studied, and we should have more reliable data on this. So the ovary insufficiency is a result of chemotherapy. It has been proven over quite representative studies. We have here, it was manifested during the breast cancer and other studies. So the early effect is identified, and then the function of the ovaries is restored. When we studied the effect of the chemotherapy in children, they also have the early onset of ovary insufficiency and reduced impaired fertility. So what can we do about it is the question that we addressed. We have different methods to like hyperthermia. We have colon stimulating factor. What is it that we can rely on to preserve the amount of them? All the experiments are either in vitro or in animals. However, one of the last studies in 2020, we had some data on protecting ovaries using all these inhibitors. Angiolitsin is one of, or just inhibit tyrosine kinase, AMH, crocetine, and others. MDRs and nanoparticles that block the stromal, that produce stromal damage, and other drugs, this CSF and sphingolipids that have a positive role in the process of protecting ovaries. If we look at what is proposed as a result of experimentation, we see we know that antioxidants and tamoxifen and others are different antioxidants and other agents can be helpful here. So we can use them at different stages of the maturation and development of oocytes.
Слушайте, ну, не слышно. Слышите?
And most of the studies available today deal with ferroprotectors. Melatonin protects oocytes quite successfully, and several mechanisms of protection are available during chemotherapy, like these ones. They are of direct action, acting on the ferment that is helpful in the process. So you can see samolin and metinit here. P3kin inhibitors, melatonin and others here. So the agonists of the GnRH is mostly studied now. So this is the oldest and the best known method of protecting the ovaries through medication therapy. So the agonists of the CAG are also studied in works that indulge upon a comparative analysis. And in these studies, it was demonstrated that menstruation resumes in the group with goserelin, compared with 7% in the control group. However, if we look at the guidelines of the Escher female fertility preservation guideline group development, here we see so there's the LGLH is a little bit late in acting, and as there is no reliable data that we could be governed by. In conclusion, I'd like to sum up the major points that I've been dwelling upon. We saw that the number of women in the reproductive age developing malignant neoplasia is growing year after year. So the most long-term toxicity is the follicle defects and destruction, and the symptoms of menopause in the premature artificial effect is quite harder than in case of a natural menopause. and this harder course of artificial menopause is to be avoided. However, a lot of potential agents to protect ovaries is at the experimentation stage or are being studied, and as there are no reliable data yet available, so it is too premature to recommend any agents or drugs. Ladex is the one that is still not included in the standard guidelines. However, it is used. We're waiting for the good, convincing database to promote it further. So it is very important to increase the development of the ovary protection techniques in the future. Thank you very much, Svetlana. Are there any questions or comments? So I just came to visit and found myself in the midst of a conference. I'm very happy to see you anyway. So may I offer a comment? Please go ahead. Thank you very much for a very thoughtful presentation, providing some fundamental explanations for the action of some of the chemotherapy agents. However, from your presentation and from the analysis of the published international findings, including the Russian data, we understand that today 100% adequate protection of the ovaries in the process of chemotherapy with the just toxic action of cytostatics is not available, right? Yes, and so what we should do, we should be looking for such drugs, and at the same time we need to join our efforts to develop new technologies that will provide for the preservation of the genetic material of egg harvesting before we start curing our cancer patients. So the more we deal, the deeper we go. We understand. The more we understand that this is a mammoth work still to be done, and a lot of research is further needed. It opens up new challenges that we are facing, and it is very gratifying that we consolidate our efforts and that we could together develop a certain strategy to help our reproductive age patients, cancer patients, not to increase the relapse cases, but together with reproduction specialists, just to help them socialize and become just enjoy have the joys of parenthood. Can I ask a question? Maybe you both could offer a comment on the following. Before you started treating breast cancer, the strategy of sparing fertility by hyperstimulation to acquire no oocyte, but just we can just use this alginate with the neoadjuvant therapy. However, a patient who is under treatment of the breast cancer approached me, and maybe I could use your second opinion, especially of a chemotherapist. the patient already got neoadjuvant chemotherapy, and she is to be undergoing adjuvant. And the interval between the operation and adjuvant therapy, the patients come just for the acquisition of noocyte and eggs. Can we stimulate such patients and acquire an oocyte? Or what is your vision? What is your perspective of such a case? What do you both think? As a chemotherapist, and we always discuss it with Svetlana, I don't mind. I'm not against it. Tatiana Alexeyevna says that there are some lesions as a result of chemotherapy. So the earlier the patient approaches us, the better. However, this can be used at any stage. I'm supportive of this strategy in my but a practical question here is, as a rule, we are approached by patients after surgery when they are quite young and they are in for the adjuvant course of chemotherapy, and we need to decide yes or no. We should be very carefully acting and while choosing the management strategy and treatment strategy. If we could use the natural cycle, we do this without involving any specific agents. However, if the patient's condition is not perfect, and if we have a short period of time before the neoadjuvant therapy is appointed, I understand that there is no other choice. So I agree with Svetlana. So the question that you asked about the different varieties of the breast cancer, we speak about breast cancer today because it's the most common pathology in reproductive age patients. Now we are not attacking with triple negative cancer and other difficult cases, because the latter case is not very promising in terms of the disease prognosis. However, the healthcare ministry guidelines, we use the 16 CGN CAG, and we very successfully treated the triple negative cancer. We are treating successfully such patients, and we are analyzing the surgical alternatives after neoadjuvant therapy. But in this category of patients, unfortunately, no genetic material can be saved after the treatment. This is a very difficult group of patients, and as oncologists, you will understand me, because cancer is not a homogeneous disease. We cannot identify localization-based strategy, be it breast cancer or cervical cancer, and maybe it is to be decided on a case-on-case basis.
In point of fact, thrice negative cancer is better than central positive, reflected positive cancer. It's better, and I think 2 weeks for stimulation do not impact drastically the patients. Triple negative, we refer them to treatment. Moreover, there is a very big bulk of data about triple negative pregnancy improves the prognosis. You are quite right. We're all aware of that, but it was about something else, that sometimes patients in the process of chemotherapy turning to us, and we should make a decision. Prognostically, it's not very benign tumor if we think about other types, so BC and 16 rounds of chemotherapy. This is for the oncologist. They should refer the patients to productologist specialists in due time prior to the treatment from cancer. Well, another question, maybe for Svetlana, in relation to chemotherapy against the background of pregnancy. How many rounds of chemotherapy, mindful of breast cancer, and as to cervical cancer, whereby it's not new, it's more like no adjuvant therapy in the integrated treatment of cervical cancer. As to cervical cancer, if it's tumor outside pregnancy, so there should be 3 rounds of chemotherapy. If there will be a surgery during pregnancy, the situation could be different, and we're interested to prolong pregnancy in the interest of a baby, but at the same time, we should not forget the interests of priorities of mother in such a situation, and that's where the number of those rounds of chemotherapy could be more than 3. And whether we're right or not, I don't know. Svetlana, what's your take on it, mindful of your vast background? The largest number of rounds of chemotherapies, it was 5 rounds, but it was head and neck cancer. The effect was aggravating. In 35th gestational week, we finalized 5th round of chemotherapy. Cervical cancer, there were patients who underwent 4 chemotherapy rounds because we were making tests, stabilization or partial effect in some of them, but we were fearful to leave the patient without any treatment whatsoever because it was necessary to prolong the pregnancy. So in cervical cancer, there are cases when there are 4 rounds at earlier terms. We started chemotherapy, so could be 4 rounds. Then we test placenta throughout the delivery. There were no pathologies of placenta in such patients. Quite normal. Apgar, according to Apgar scale, everything was all right, and there were no abnormalities and pathologies for those neonates. As to head and neck tumors, full effect for all. As to cervical cancer, if the effect is good for neoadjuvant chemotherapy, by the same token, then there is cesarean section and maybe, and after that, radiotherapy, if there is no effect after that. Thank you very much, Svetlana. Are there any comments? Marina, the audience? Microphone. Use microphone, please. Thank you so much. It's so great that we can discuss different topics here, and I'm very glad that our community has been growing and extending, and through joint endeavor we can reach a lot. Thank you so much. First of all, we appreciate our experts, our colleagues were able to join up in Zoom to our meeting. I would like to extend my heartfelt thanks to the audience for participation in the symposium, and it's rather judgmental, highly judgmental topic, but Moscow and St. Petersburg colleagues display lots of ideas and developments on this subject matter. And I'm looking forward to our future meetings. It will be great to meet all offline. Well, I have the pleasure of inviting you to St. Petersburg next year, though, but it will be offline, I'm sure. Thank you very much for your participation, and see you soon in future. Thank you very much, Yelena, Marina, Tatiana. Thank you very much.